So this is my presentation on odontoma. So there's three different types. There's compound, complex, and simple. Compound is looks like a bunch of small teeth, almost like a bag of teeth. And complex is more of like a gnarled mass of like enamel, dentin, cementum, and pulp, and it doesn't really look like a tooth. And then the simple is going to be like 100% like a single tissue, but I'm going to talk more about the compound and complex. So if you look at the top picture, you can see the compound odontoma looks like that bunch of little teeth. And this was if it were to erupt. Usually it's found radiographically, and it would commonly be found, the compound would be in the maxilla in the anterior, and then the complex looks more of like that gnarled mass, and it'd be found in the mandible in the posterior. And it's usually found if there is like a failure for teeth to erupt, and they can sometimes cause like displaced teeth or malocclusion or swelling. And they usually grow slowly, and they can exhibit concrescence, fusion, and laceration, and they can be 6 centimeters but are mostly between 1 to 2 centimeters in size. Radiographically, the compound, like I said before, is going to be that like bag of teeth looking, and it's a bunch of little tiny teeth with like a radiolucent halo, and it's usually in the anterior maxilla. The complex is going to be that radiopaque mass surrounded by a thin radiolucent halo and found in the posterior on the mandible. Historical description, the pathogenesis is benign and non-aggressive. There's not really a certain sex that it presents more in, but it's usually found more in adolescents and young adults. The cause is unknown, although sometimes like if there was history of trauma, or if there's like heredity anomalies like Gardner-Herman syndrome, that is thought to be a cause. For compound, it's going to be more of that or like arranged in an organized manner, while the complex is kind of disorganized. For lab results, since they have a lot of similarities and could be associated with a lot of things, it is recommended in all cases to have some testing done. And then amnioblastic epithelium has been found more with the complex, and then mesenchymal tissue is more found with like compound. And then for the microscopic analysis, the compound, as you can see, is more like in an organized manner, while the complex is kind of disorganized and has like dentin-like material and enamel prisms. Surgical needs is surgical inoculation, and usually there's like an excellent prognosis, and sometimes depending on the time of when it was removed, there is some relapse that might happen. And other therapeutic needs, sometimes they'll do ortho treatment. So if you look at the radiographs, you can see they could kind of see the odontoma there, and so they actually started ortho treatment. And then right around here, they actually removed it, and then during healing, you can see that there wasn't any resorption or root damage going on. Yeah, and there also can be pain medication if the patient is having some discomfort. And sometimes, if left untreated, then there can be a dentigerous cyst that appears. So differential diagnosis, there's a lot of things that odontomas can look like. So depending on the certain areas, it might resemble different things. So I really wanted to show you too the osteoma versus the odontoma. You can kind of see they're very similar, except for there's no like radiolucent halo on the osteoma versus the odontoma. You can kind of see it right there. And this is another just differential. You can kind of see the odontoma has that halo going on, and then the osteoma doesn't. And then this was my intraoral lesion that I found in clinic on a pan for my patient, and it was an idiopathic osteosclerosis lesion, so meaning there was like no cause for it. And you can see on the apex of the mesial root of number 19. The patient didn't have any pain associated with it, but he did mention that when he was younger, he was kicked in the face by a horse. So actually might be related to trauma. And this is another just example of what idiopathic osteosclerosis would look like, and how it's like right close to the root, which is similar to the lesion that we found. So for this lesion, clinically, you wouldn't be able to see it in the mouth, but radiographically, it's radiopaque, and it can be round, elliptical, and irregular in shape. And it's usually found at like the root apices of the mandibular molars or premolars. Historical, it's asymptomatic, benign, dense, localized radiopaque lesion with unknown cause, or again, sometimes associated with trauma. For laboratory, usual diagnosis is still radiographic, but biopsy and CT sometimes are needed, but it's pretty rare. And then microscopic, it's for like the tissue, it would be like appearing stratified squamous epithelium with irregular hyperplasia overlying a densely infiltrated inflamed stroma. If you're looking more at the bone, it'd be bone tissue examined would show like a irregular Haversian system and numerous osteocytic leucinae and concentric lamellae. Surgical, there's not really any treatment unless there's root absorption starting to become an issue, then they would surgically remove it. Therapeutic usually is like follow-up x-rays, and if needed, they may need to extract the tooth and possibly have a implant placed. For differential, when associated with a root, a regular PDL space is maintained and the tooth is vital. On a CBCT, it will blend into adjacent cortices with no thinning or expansion. And the features help differentiate idiopathic osteosclerosis from similar entities such as condensing osteitis, cemento-osseous dysplasia, hypercementosis, and cementoblastoma. So in conclusion, we let the patient, we told them a little bit about it and showed them the x-ray, and then Dr. Demas was able to diagnose off the radiograph. And she said that we should, at the next appointment, follow up with a PA and just monitor for any signs of growth. Thank you.